Very good afternoon. So after a lovely interaction from the dermatology department, we from CDER, the Department of Oral Surgery and Maxillofacial Surgery, is going to present a rare case, an interesting case, I think, which would also keep us occupied thinking what this lesion is. But yes, it is a rare identity. It is not a very common identity as it was in the dermatology discussion. I hope everybody would be engaged, and my presenter is Dr. Krishna. She is the team leader. She would introduce the other members who would be speaking on this case. Please, Dr. Krishna, could you please come over and talk something about the team who is going to talk about this case. Thank you.
Thank you very much, ma'am, and a very good afternoon to everyone. So as ma'am said, yes, this is a rare case, but then as maxillofacial surgeons working in the area, we are mostly artistic people. We are more focused on the procedure, so hardly ever we get to use our brains. So that way, yeah, it was interesting. It has been interesting dealing with this case. It presented to us in mid 2018, and it had involvement from radiology for diagnostic purposes, which is a usual scenario in any pathology, that we want to know whether it's a malignant versus benign. That's the first thing we would want to know. And then once we get to know that it's benign, then there are various things. Do we do enucleation, or do we cure out the lesion? Do we do resection, and then how are we going to reconstruct? So this is the usual part. But the unusual part in this particular case was certain other features for which we required help from endocrinology department, help from genetics department. And so we thought it's a good case to present this afternoon. So let's start with our senior resident, Dr. Devraj.
Thank you, ma'am, very much for the kind introduction. And without further ado, Chinese letter versus sand grains, a case of rare familial entity in the Department of Oral and Maxillofacial Surgery at CDER AIIMS. A 17-year-old male presented to us with a chief complaint of swelling in the lower jaw for the past 1.5 years, which had insidious onset, gradual increase in size. There was no associated pain or loss of sensation. And previously, patient had a history of surgery for a similar swelling in the maxilla in 2006 under general anesthesia. Unfortunately, reports were not available, and 1 unit of blood transfusion, however, was done at that time. From family history, the father had passed away, and he had a history of femur fracture. Patient had 7 siblings, 5 brothers and 2 sisters, all of whom were affected by some skeletal abnormality, except one girl. The affected sister, however, had jaw swellings as well, just like his brother. In personal history, the patient was a student with normal appetite and bodily habits, with no deleterious habits, and general examination was unremarkable with normal gait. Systemic examination was again unremarkable with broadened digits, as we can see, brachyinclinodactyly of the right index finger with short and broad distal phalanges of the upper limb. Local examination, there was a 10 into 11 into 6 centimeter size swelling, which was well defined and extended from the left corner of the mouth and extended beyond the lower border of the mandible up till the thyroid cartilage, mediolaterally from a mid-pupillary line of the right eye to the zygomatic prominence of the left side. And on palpation, the temperature was normal, and it was non-tender, well-defined, bony hard swelling, and it was non-compressible, non-fluctuant, non-pulsatile. There was no paresthesia or fixity of skin or lymphadenopathy that was associated with the swelling. On intraoral examination, there was evident swelling of 3 into 4 centimeter in size, which involved the entire palate. Mucosa was largely normal, and the loss of teeth of the left side of the maxilla is evident. On aspiration, it was negative. The swelling of the mandible, similarly, was of the left side, which crossed the midline at the size of 8 into 6 into 4 centimeters, extending from the right canine region to the left molar region. Buccal and lingual vestibules were obliterated. As you can see in the picture, the tongue was elevated because of the space occupying expansion of the floor of mouth from the lingual aspect of the mandible, and obvious displacement and crowding of the teeth and mobility of the left lower second premolar. Aspiration again was negative. Now, our blood investigations will be dealt with extensively by our endocrinology colleagues, but I want to draw your attention towards the mild anemic picture and eosinophilia, as well as highly raised alkaline phosphatase in this patient. The OPG again will be taken up by our radiology colleagues. However, we would like to point your attention towards the osteoexpansile osteodestructive lesion that caused extensive displacement of the teeth. However, if you note carefully, there is no root resorption present. Based on these preliminary findings, we can formulate a differential diagnosis, and on top of that, we'll focus on fibrous lesions in this case. Fibrous dysplasia, it commonly involves the skull and facial bones, and in 50% of the polyostotic forms will involve the jaw. And the craniofacial form presents about in the first 2 decades of life. It is associated with malalignment and displacement, but not resorption of the teeth. And the presence of endocrinopathies with aspiration is negative because it is a solid lesion mostly. And radiographically, radiolucent radiopaque picture with displacement of teeth can be found. But is there any report of a familial fracture? If you go through Marks and Stern 2012, we all know it's due to the defective or absent GNAS1 gene. However, there is no evidence to suggest a hereditary influence. However, on further perusal of literature, we identified a few cases. Reitzig et al. In 1975 reported the first ever case of familial transmission in a 10-year-old boy with involvement of the mandible and the skull, whose father had multiple well-defined lesions in the skull as well, and there are various family members who had these lesions, and FD was present in every generation in that family, but only in children of affected fathers. From this, they concluded an autosomal dominant trait of inheritance. Similar case by Zohar et al. 1989. They were able to trace every thrower of the jaws through 4 generations of family members in an autosomal dominant manner, some of whom had histologically cherubism, and while some had FD. Now this is where things get interesting. You see the lines between fibrous lesions of different types of cherubism, fibrous dysplasia, or ossifying fibroma start to blur. And another case of craniofacial dysplasia, craniofacial fibrous dysplasia, this form noted by Pierce et al. In 1985, they reported a mother of 34 years old and 2 daughters, 8 and 10. Interestingly, all 3 of them in their childhood had been diagnosed with cherubism because of bilaterally symmetrical mandibular expansions. However, biopsy at the time of presentation revealed fibrous dysplasia histologically. Now, the most unusual thing in this case was that both the daughters demonstrated replacement of dental pulp by fibrous tissue similar to fibrous dysplasia. Another report of familial craniofacial dysplasia, Mangian et al. In 2000 from the follow-up of 20 years of a single family. Now, in the differential diagnosis, will we consider cherubism? Most likely not, because it shows bilateral symmetrical involvement of predominantly the posterior and the posterior mandible and the maxilla, which results in a cherub facies, and it presents within the first decade of life, and a characteristic radiographic picture is present of bilateral involvement. However, if there is a rule, there will be an exception, and as usual, we found another case report of unilateral cherubism. Now, ossifying fibroma, of course, we'll consider that because it is common in young adults. It has a mandibular predilection. It is associated with malalignment and displacement of teeth, and it's common in the tooth-bearing areas of the premolar and molar regions, but it is limited to the jaws. It does not show systemic involvement, right? So, have you ever encountered a case of ossifying fibroma with pre-existing craniofacial dysplasia? We have not, but there is one case report in Marks and Stern 2012 where we can see this picture of a fibrous dysplasia present, from which is arising a lesion of ossifying fibroma in this young African-American male child. So, odontogenic myxoma would be another differential diagnosis, as it is commonest in the 2nd to 3rd decade of life. There is a predilection for tooth-bearing areas of the jaw, and tooth resorption is common in this case. As you can see from this OPG of a patient afflicted in our department presented 2 years previously. Now, the last central diagnosis, central giant granuloma, just to be thorough, it occurs in commonest in the 2nd to 3rd decades of life, and it has a mandibular predilection as well, and is common in the anterior mandible and frequently crosses the midline. But a lesion of this size should yield more often blood, right? And lesions are commonly known to perforate the lesions of this size are commonly known to perforate the cortex and cause tooth resorption mobility, which was not very Reverend. Thank you. That's all. Now I'll hand you off to our radiology colleagues to show the radiologic diagnosis.
Thank you, sir, for briefly describing the differential for this case. Good afternoon, everyone. Coming to the radiology part for this case, this is the OPG of the index case. We can here see there is an expansile rhytic lesion with sclerosis within the lesion, causing the marked displacement of the tooth. However, there wasn't any erosion of the tooth. We can also appreciate there is a displacement of the teeth of the upper jaw also. The CCT phase for this patient has also been done. This is the bone window. We can see the mandibular region. It shows the well demarcated margin from the normal adjacent bone. So, along with that, there is a calcification. There is also matrix ossification. So, likely this is suggestive of the ossifying fibroma, not the fibrous dysplasia. Apart from that, the patient's the maxillary region, it shows the bone expansion. It is extending to involve the zygomatic arch, hard palate, and shows the ground glass appearance. And in additionally, this calvarium of this patient was diffusely thickened, and multiple ground glass focal lesions were also appreciated. The skeletal survey of this patient additionally revealed, apart from the skull finding, there are multiple geographic expansile lytic regions which were seen involving the ribs, fourth ribs and fifth right ribs. Additionally, we also see there are a small eccentric intracortical lesions with sclerotic margins which were seen in the proximal diaphysis of the femur. We also see there are osteolysis of the distal phalanges which were seen involving all the digits. Here there is another expansile lytic region with multiple septation which was seen in the phalanx. Similar morphology lesion to the humerus also seen involving the radius. The spine for this patient was unremarkable, because however there was a symmetrical lesion in the bilateral intertrochanteric region of the femur with ground glass matrix. A few lesions similar to the humerus are also seen involving the distal diaphysis of the femur, and we can also see the fibrous dysplasia type lesion which was seen involving the metatarsal, and there was a diffuse osteolysis of the distal phalanx. The siblings has also underwent imaging. The OPG of the siblings, it shows the multiple circumscribed lytic lesion with the septensor which seen in relation to the root. However, there wasn't any root resorption. Impacted tooth can also be seen. Apart from that, there was a sclerotic lesion which was seen ill-defined margins in the right maxilla. Skeletal survey additionally revealed a few sclerotic focal lesions in the skull. The chest and spine and appendicular skeleton were normal. In the lower limb, we can see there are eccentrically small intracortical lesions with circumscribed margin, sclerotic margins, which were seen in the both distal end of the femur, in the proximal distal diaphysis. However, the pelvic bones and the tibia and fibula were normal. So, the radiological impression together for this patient, in the index case, the mandibular lesions likely to represent the ossifying fibroma. In the maxilla, the lesions with ground glass matrix in the maxilla, zygomatic arch and hard palate with multiple focal lesions in the calvarium likely to represent the fibrous dysplasia. The lesions which were in the ribs, in the intertrochanteric region of the femur, metacarpal and metatarsal, they morphologically looks like a fibrous dysplasia. And the intracortical lesions which were seen in the humerus, radius and distal femur, they likely to radiologically appear like a non-ossifying fibroma. And there was acro-osteolysis involving all the digits in both upper limb and lower limbs. In the siblings, the lesions which were seen in the mandible, they are very well circumscribed, multiseptated, so likely to represent radiologically as ossifying fibroma. The ill-defined lesion with sclerotic areas in the right maxilla, it could be either fibrous dysplasia or ossifying fibroma. The other intracortical lesions which were seen in the distal femur of the sibling, it likely to represent the non-ossifying fibroma radiologically. So overall, these represent the polyostotic fibrous dysplasia with multiple ossifying and non-ossifying fibroma and acro-osteolysis involving all digits. Thank you.
Good afternoon, everyone. I'll be dealing about the endocrine aspects of this case. My preceptor is Professor Dr. Rajesh Gargawat from our department. So these are the points that we considered for making the differential from our side. One, the child was having bony dysplasias involving multiple bones, and these could be fibrous or fibro-osseous lesions. But imaging wise, it looks like an expansile lesion and lytic lesion, and there is a definite evidence of acro-osteolysis was there, which is there both clinically and imaging wise, and there is a strong family history was there. And metabolically and hormonal profile seems to be normal except for raised alkaline phosphatase, and there is no other system involvement. So our differentials were, the first was polyostotic fibrous dysplasia, we'll see subsequently, and second was cherubism. This has been already dealt with, so I will not be dealing further. And third possibility that we kept was juvenile Paget disease and the other similar syndromes, which includes familial expansile osteolysis or expansile skeletal hyperphosphatasia. And lastly, because of acro-osteolysis, we would like to just put few differentials and try to see if something could fit into our case. So coming to fibrous dysplasia, this is syndrome where there is a replacement of normal lamellar cancellar bone by abnormal fibrous tissue. So this could be monostotic or polyostotic or panostotic. So this could be associated with endocrine component in the form of hormonal hyperfunction or other non-endocrine features, especially skin. And so the pathogenesis is basically a mutation in GS alpha subunit which occurs in the post-zygotic state. So coming to our case, the things which are in favor of this syndrome is one, presence of multiple skeletal lesion like lytic or expansile suggestive of fibrous dysplastic lesions, and age of presentation. But things that goes against is the mode of inheritance. Like our case looks like to be a sort of autosomal dominant, which is not supposed to be a case of fibrous dysplasia. And acro-osteolysis is not something we see very commonly with fibrous dysplasia, and ossifying lesions also not common. And our case did not have any endocrine excess or other exoskeletal features, suggestive of McCune-Albright syndrome. So the second entity that I am going to deal with is juvenile Paget disease and related disorders. Though there are many other genetic etiologies has been put for this, but for our discussion, we will be seeing specifically the mutation involving rank ligand. So they are characterized by early onset deafness and premature loss of dentition. And a classical juvenile Paget disease due to rank ligand has both axial and appendicular skeletal involvement, and its related disorder, that is familial expansile osteolysis, which involves predominantly of appendicular skeleton with expansile lesions and also bone deformities. And another related disorder called as expansile skeletal hyperphosphatasia, which is in fact related to juvenile Paget disease and this familial expansile osteolysis, is similar to FEO, but it in addition has sclerosis of skull and also has intermittent hypercalcemia. And all these disorders due to an activating mutation in rank ligand, and which in turn causes an increase in osteoclast function. And they all have an autosomal dominant inheritance. So coming to our case, the things that are in favor of this diagnosis of Paget disease or Pagetoid syndrome are one, presence of multiple skeletal lesions, that is lytic and expansile lesion, and age of the presentation, that is in second decade, first and second decade or usual age in which these syndromes present, and mode of inheritance, autosomal dominant, and isolated raised ALP, though it's not very high in our case. And the things that goes against is there is no hearing abnormalities or no premature loss of dentition, and acro-osteolysis is not something which is very common with these syndromes. And ossifying fibroma on jaw or FD-like lesions also not fits here. But we cannot rule out this syndrome at this stage. It requires an histopathology which will be dealt subsequently, and genetic studies which are yet to be available in our case. Because acro-osteolysis was there, which did not fit into earlier two DDs that we put forward, so I will just put here a slide describing the causes of acro-osteolysis, which includes commonly endocrine causes, includes hyperparathyroidism, acromegaly, and rheumatological conditions including scleroderma and sarcoidosis, and also vinyl chloride exposure, which also causes a syndrome similar to scleroderma, and diabetic neuropathy, and also leprosy. But in the context of autosomal dominant, so we want to focus on genetic causes which include pycnodysostostis and Hadju Cheney syndrome. We know pycnodysostostis is a very typical syndrome that has a typical facial and appearance, so it does not definitely fit into our case. So this Hadju Cheney syndrome, here there is a mutation in exon 34 of Notch2 gene that creates a truncated protein with enhanced function. So they have acro-osteolysis, and they also have coarse facial features such as microganthia, cleft palate, prominent occiput, and also dental abnormalities. They also have severe osteoporosis and they are prone to fractures. And child will also have short stature and deformities of long bone, but there is no description of dysplastic or expansile lesions. And cardiovascular abnormalities such as ASD, VSD or PDA could be there, and also renal abnormalities such as polycystic kidney disease can be there, and also platyplasia and basilar imagination. So coming to, in our case, the things which are in favor of only one thing, that is acro-osteolysis, and second is mode of inheritance, which is autosomal dominant. So there are a lot of things that goes against, which includes there is no other systemic involvement is there, and no typical facial features, and presence of dysplastic bone lesions, which makes this condition very unlikely in our case. So with this I conclude my presentation from endocrine aspect. Ask the next speaker to continue further. Clinical possibility, the first one is polyostotic fibrous dysplasia. So that is still there.
Good afternoon, everyone. I am Ambika Gupta, and I'm a senior resident in genetics division, and have been mentored by Dr. Intra Gupta. And consultation was sent for our review regarding this case, and most of the differentials have already been discussed. So from the pedigree, we were sure that it was an autosomal dominant disorder with variable expression, as only one of the patients had that typical acro-osteolysis type lesions, and there was mild variation in the skeletal deformities that different patients had. Then there were jaw lesions which were suggestive of an ossifying fibroma, other skeletal lesions which were more suggestive of a fibrous dysplasia like picture. Then there were endocrinal disturbances which included insufficient vitamin D, high growth hormone level, and a high alkaline phosphatase. So things were not fitting into one particular diagnosis, because if we consider fibrous dysplasia, it is mostly associated with a somatic mutation in the gene AS gene, which is definitely not heritable. Then if we consider ossifying fibroma, then other features were not clearly fitting into the diagnosis. One of the entities like hyperparathyroidism too with jaw tumors, which is autosomal dominant entity with haploinsufficiency in the CDC73 gene, is associated with a familial occurrence of ossifying fibroma, but then there was no hyperparathyroidism in our case. Another possible diagnosis that we considered at that time was Paget's disease of the bone 2, early onset, which is also an autosomal dominant disorder associated with the TNF-RSF11A gene, which encodes for the rank ligand on chromosome number 18. There were some pointers for in favor, that was autosomal mode of dominant mode of inheritance, then swelling and deformity of the mandible. There was premature tooth loss, there was enlargement of bones, although after the radiology it was only an acro-osteolysis. Then elevated alkaline phosphatase, onset in teens. It was a progressive disorder and had a variable severity. However, there was no hearing loss, there was no swelling associated with the IP joints, and no gross deformity or bowing of the long bones was noticed. So this was probably out of the differential diagnosis. And as such, in the end, as such, we did not have a clue to a particular diagnosis. So we sent a whole genome testing for 4 affected family members. And when the reports came, there was no sequence variation and no structural variation, no deletion or duplication that was detected in the reports. So we are probably missing something, and that makes the case even more interesting. So if a disorder is not, like we are not able to pick it up on whole genome, then there could be still other mechanisms like epigenetic modifications or some chromatin remodeling that may not definitely be coming in the sequence testing. So we need to go further deeper into functional studies, which may include proteomics, expression studies at the site of the lesion to study actually which pathway is being affected, and maybe in a reverse manner we can go and find out what is happening wrong with the genome. definitely there should be something that we will be able to come up, and this functional study is in progress. Thank you.
Good afternoon. After all these endocrinology and radiological discussion and workup done, the incisional and excisional biopsy of this lesion was done. However, I am not discussing about that part, which will be discussed after my part, because it needs discussion, and I am only discussing about my intraoperative parts. After that, all these departmental discussion, we came to a conclusion, almost came to a conclusion that it is a fibrosis lesion, which is mainly a benign lesion, and it can be easily demarcated from rest of the normal bone. So we decided to do the curettage and the aesthetic recontouring of the lesion. However, before going into OT thing, we decided to some surgical challenges must be there, and authors have reported that most of the fibrous lesion can be present as a hybrid lesion, either with an ABC, aneurysmal bone cyst, or central giant cell granuloma, which can cause a massive intraoperative loss of blood. So we did a CT scan, which reveals there is no fluid levels, and we can we accept that it is not a hybrid lesion. Other challenges which we can face in the future is the aesthetic deformity or the any functional loss, because as the lesion is a huge lesion, and it is present in almost most of the mandibular part. So we decided to go through the curettage and aesthetic recontouring of the lesion. For the incision and wide exposure, we did an visor incision, and we can appreciate in this figure that most of the lesion can be exposed by this incision, and we did the removal of the lesion with the help of piezoelectric, and the other instruments which we can use are the rotary instruments, and with the mallet and the chisel. After removing most of the lesion, we are only left with a thin lingual plate of bone. So we decided to do an reconstruction with the help of an reconstruction plate, which is actually a load-bearing plate. And now the question arises why the reconstruction was necessary. Because after the removal of the lesion, we felt that only a thin plate of lingual plate was left, which in future might cause a pathological fracture. So we use a surgical template for the bending of the plate, and the other method which we can use a 3D printed recontoured reconstruction plate, but it is a costly affair, so we decided to do with an surgical template. And after doing the reconstruction, this is the final picture. We can see we have reconstructed the mandible with the help of a reconstruction plate. And after going through the literature, we found that recurrence rate mostly occurs during the 6 months to 7 years of follow-up, with an average recurrence rate of 10.1% during an average follow-up of 25.3 months. In the literature, there was only one case of malignant transformation was found, in which it transformed into osteosarcoma, whereas authors have suggested a long follow-up period should be required, because one author has reported recurrence rate even after the 18 years of follow-up. After this, I will hand over the rest of discussion to Dr. Cheney, who will discuss about the histopathological thing.
Thank you very much. After a detailed clinical, radiographic, endocrinology, genetics discussion and such, I'll be discussing the histopathological final diagnosis part, and the main part that will be defining the title of our discussion today, Chinese letter versus sand grain, because the audience might have thought why this title, and that will be justified by the discussion on histopathology. So we will be starting with the
discussion on the histopathology. What we could observe after histopathology and decalcification of the tissue, as the tissue we received were firm and gritty on cut surface, so that we could appreciate that there was calcifications in the tissue, and that was justifying the earlier discussion of a fibrous lesion. When we could go in a low power, we could observe three types of calcification in our tissue. This area, which is zoomed by me, this has interlacing trabeculae of normal bone, which we could observe that it is type of a normal calcification which is going on. Then there was a second area in this, we can see in the zoom window, there was a very loose fibrous tissue where we could see the bony trabeculae in a Chinese letter pattern. There was curvilinear calcifications, and on the periphery of this tissue, and center and periphery, where we could see small droplets of calcification, similar to the sand grains what we have in the titles. So this was the basically our dilemmatic situation, because fibrous lesions have histopathology which is interlacing and which is confusing. There is a much more overlapping in all the fibrous lesions that we need to justify after proper clinico-pathological and radiological correlation. Now at a high power, we could see the stroma was very hypercellular. The proliferative fibroblast spindle cells were present with the different types of calcifications. And we could see these are the globular calcifications in the hypercellular stroma. Now I'll switch back to the discussion with the we received the gross specimen in form of multiple firmly formed tissues which were gritty on cutting, and there was hypercellular stroma with the predominant pattern of calcification to be in form of samomatoid bodies. This terminology is derived from a Greek word samoma that is meant as sand grains. And these were calcification with the peripheral, the homogeneous eosinophilic portion which we can see around the calcification, that is the osteoid deposition, which is lined by osteoblast. These are calcification, and we could see the osteoid and osteoblastic rimming in these. Calcification initiation in the osteoid. Now coming to the differential diagnosis, which we considered on basis of histopathology. The first one is the type of ossifying fibroma. The ossifying fibroma has three entities: cemento-ossifying fibroma, which is basically a tooth origin of the dental origin, and it is presented in the tooth-bearing areas. Then we have two forms of juvenile type, trabecular and samomatoid, which had this entity which had similar presentation. All these things we could see in our lesion in different areas. Then there is an entity of fibrous dysplasia, in which we can observe the bland fibroblastic cells and irregular shaped trabeculae of immature bone, which present in a curvilinear form or Chinese letter. And one a little malignancy which we have to rule out is that low-grade osteosarcomas sometimes might present in the similar fashion of a benign fibrous lesions, that we need to rule out with the help of immunohistochemical markers by CDK4 and MDM2. Now coming to the final diagnostic points which we have enumerated. Our first is the clinical, that patient is young and no associated hormonal derangements could be observed. Then the radiographic, the lesion was with well demarcated margin and from the normal bone. Intraoperative also it present as a well circumscribed lesion with distinct boundaries. Then macroscopically the tissue was firm, tan and gritty on cut surface. And microscopically the important points coming to diagnosis were hypercellular stroma, calcification in samomatoid and trabecular concentric patterns, where the predominant pattern was samomatoid type, and the osteoclastic or osteoblastic rimming of the bony trabeculae. Now final histopathological diagnosis which we came is to the primary lesion was juvenile samomatoid ossifying fibroma. Now coming to the clinico-pathological and radiological summary, we could observe that there were multiple lesions which were diagnosed as ossifying fibromas. Also we received from the female sibling of the current case, she had two ossifying fibromas which were histopathologically proven, and 5 brothers and 1 sister, that siblings were involved, and the patients were young, less than 18 years of age. Now coming after reviewing the literature, we could find that the 18 cases of sporadic multiple ossifying fibromas have been reported in the literature without a familial tendency, and 24 cases of hyperparathyroidism related jaw tumor syndromes are reported. And 2 cases with the familial tendency of multiple ossifying fibromas, in one case where the daughter and mother had the multiple lesions, and in second case the father and the daughter had multiple and singular lesions. After now, with the conclusion of all the findings, we could see that the lesion had familial tendency, the cases were multiple, and patients were young. So the final conclusion was familial multiple ossifying fibromas. Now, concluding the presentation, according to the existent literature, this was the 3rd reported case of familial multiple ossifying fibromas. As fibro-osseous lesions present as diagnostic dilemma, as the histopathological spectrum is overlapping, as in the first scan slide we could see there was a presentation of few focal area of fibrous dysplasia also, trabecular ossifying fibroma also, and subomatoid ossifying fibromas also. So the predominant pattern which could observe was subomatoid, so we came to the diagnosis of juvenile subomatoid ossifying fibromas. Thank you very much.
Thank you, Dr. Sunny, for giving a wonderful insight into the histopathological picture, which is actually a tiebreaker, which proved to be a tiebreaker in this case. As is usually, I would say, for any surgical pathology, the histopathology people, in this case, Dr. Deepika and Dr. Asif Ranjan from the general pathology, they both were involved. Here the 3 things were confusing. One thing, polyostotic involvement, that of cranium, that of jaws, and that of long bones, and so that is one part. Second part is it's a familial entity. And the third part is a confusing picture between the fibrous dysplasia and ossifying fibroma. So that is what was creating, because you don't get fibrous dysplasia which runs in autosomal dominant pattern in a family, and then you don't get ossifying fibromas which have long bones looking like fibrous dysplasia. However, as we came to a conclusion, this may be just a 3rd reported case ever in literature which shows familial multiple ossifying fibroma. However, the genetic studies are awaited, and maybe we will get enlightened by something new in that. So, so now house is open for questions from those present also, and from internet also. या चैट में और यहाँ पर भी any questions. नहीं है ना क्वेश्चन? ठीक है. Yeah.
But is there any difference in management and follow-up regarding this fibrous dysplasia?
Yes. Yes, so fibrous dysplasia, we would probably not treat those patients surgically often, because before they reach their growth potential, and whenever we do, it should be a definitive aesthetic recontouring rather than the curettage. Here, the ossifying fibroma is basically an encapsulated thing, you can take it out. And the lingual plate, because it was thinned out, so we reconstructed. Otherwise, if there is enough bone, then we can just leave it as such. Follow the patient for recurrence, and then if required, we can put some bone graft and then the dental implants. But fibrous dysplasia, the bone quality is gone forever. Number one, you can't take it out totally, because both the cortices will also be involved. So basically what you end up doing is bony shaving or the aesthetic recontouring. So that's the difference from our side. One can be totally taken out and one cannot be. Yeah. I guess that was incidental. So yeah, I think it was incidental, and usual practice is to give albendazole and then follow it up. So from our HOD, it would be great to have the postoperative reconstruction picture of the patient. I think that's there, so you can just put it there. Rudra can, yeah, we can put it. जैसे देखना है. I think because of time crunch, we did not show that slide, but yes. So yes, this is how he looked later on. And can you show us the other questions then? तो स्लाइड करके दिखा दो, है ना? ठीक है, एक बार YouTube पे दोबारा ले जाओ, चैट पे एक बार दिखा दो. So, Anita ma'am and Sunil sir, yeah, thank you very much, sir. How was the patient after surgery? He has been doing fine. Though he did not come for follow-up physically, but he has been in touch telephonically and he's doing good. Thank you.